Presentation of a patient having pneumothorax. Case scenario: Alan Mart, a 23 years old female, presented with sudden onset of chest pain on left side that began 6 hours earlier with non-productive cough. Symptoms began when she was at rest and pain was severe, sharp with tightness in chest. Pain was aggravated by deep breathing. There was no associated nausea, fever, or chills. Chief complaints: chest pain, cough, dyspnea. History of present illness: Alan was alright previously with no respiratory symptoms, including cough, shortness of breath, or any physical limitations during exercise or any exertional activity. Few days back, sudden onset of pain started, but she did not pay attention to it. But the pain got worsened with tightness in chest and was aggravated by deep breathing that caused her discomfort. Past history: no history of tuberculosis, no other respiratory problem in the past, no history of hypertension, no history of diabetes mellitus, no history of chest trauma, no history of previous surgery, no history of allergy. Personal history: no history of bowel and bladder dysfunction, no history of alcohol intake or substance abuse. Family history: Alan's parents are alive and she has 2 brothers. There is no history of hypertension, diabetes, tuberculosis, or any respiratory disease. Occupational history: Alan is a student and is currently studying mass communication. Social history: she belongs to a middle class family with good support from her parents. Currently she is living in hostel and has good friend circle. Treatment history: she took painkiller Tylenol before hospital admission and was also taking cough syrup Hydralane. General examination: the patient is dyspneic, conscious and is fully oriented. Her blood pressure is 120 by 80 mm mercury. Pulse rate is 90 beats per minute. Respiratory rate is 30 breaths per minute and temperature is normal. Examination: it includes inspection, palpation, percussion, and auscultation. Inspection: local bulging of chest wall. Chest movements are reduced. Palpation: displacement of trachea towards opposite side, decreased vocal fragments, diminished expansion on affected side. Percussion: hyperresonant notes were felt on percussion. Auscultation: diminished breath sounds, decreased vocal resonance, decreased whispering, pectoriloquy. Investigations: X-ray shows sharply defined edge of deflated lung, especially on a film taken in expiration. There is complete translucency between pleural line and chest wall with no lung markings. Trachea displaced towards opposite side. Hemidiaphragm is depressed. Affected side lung is depressed down. Blackish shadow shows air accumulation. And here is the X-ray of the patient. Diagnosis: pneumothorax. Medical intervention: management will be according to the area involved. As affected part is 15 to 50% of lungs volume, percutaneous aspiration will be performed with a 16 gauge cannula attached to a 50 cc syringe. Physiotherapy management: it includes ACBT, that is active cycle of breathing. It involves the following steps. Number 1, firstly breathing relaxation, inhale through nose and exhale through mouth. Number 2, secondly forced breathing. It includes inhaling through nose, stop breathing for 2 to 3 seconds and exhale through mouth. Huffing and coughing. Percussions, vibrations. Short-term goals: to treat dyspnea and pain. Dyspnea will relieve when underlying cause will be treated. Long-term goals: to relieve the pressure on lungs and allow it to re-expand, to prevent recurrences. Home plan: advise the patient to take all precautionary measures, get plenty of rest, hold a pillow against your chest when you cough, have adequate sleeping hours, that is 6 to 8 hours. Patient education: avoid activities that put extra pressure on lungs such as flying, scuba diving, etc. Take proper and healthy diet, drink enough fluids. Prognosis depends upon treatment and underlying cause. Prognosis is good if pneumothorax is small, the leak heals itself and trapped air is gradually absorbed by the body within 1 to 2 weeks. Patient's feedback: the patient wrote it as following: it was a good experience with you. All my queries are resolved now. I will follow your advice strictly. I can't fault in any way the amazing care I was given. I have been looked after by all the staff and treated well. Thank you for making my experience as pain-free as possible. And here are the references, and some references are taken from Clinical Medicine book by Anam Danish.